Okay, let's jump right in. Welcome to part 2 of our 5-part explainer series on urinalysis. In our first part, you might remember we looked closely at renal anatomy and exactly how the nephron actually forms urine. Well, today we're shifting our focus. We're going to look at what that urine actually contains, and just as importantly, the absolutely critical pre-analytical handling steps. Because as you'll see, getting the collection and preservation right is literally the foundation for reliable lab results.
To give us a clear roadmap, here is our agenda. We'll be hitting history in urine formation, urine volume variations, collection methods, containers, transport and rejection, handling and preservation, and finally wrapping up with exam must-knows. Let's get right to it.
All right, starting us off with Section 1, History in Urine Formation, the Biological Blueprint.
So, believe it or not, urinalysis basically kick-started laboratory medicine. The timeline goes way, way back to cave drawings and Egyptian hieroglyphs where they noted changes in color and odor. By the 5th century BC, Hippocrates had written a whole book on uroscopy. Fast forward to the Middle Ages around 1140, and they actually developed these intricate color charts to aid diagnosis. Though, unfortunately, it also led to charlatans known as piss prophets, who claimed they could diagnose literally anything just by looking at a sample. That actually prompted the very first medical licensure laws. It wasn't until the 17th century invention of the microscope that we could finally evaluate the microscopic sediment. Today, the Clinical and Laboratory Standards Institute, or CLSI, defines urinalysis as testing performed in an expeditious, reliable, safe, and cost-effective manner.
Behind the scenes, your kidneys are doing an unbelievable amount of work. Urine is essentially an ultrafiltrate of plasma. Your kidneys process an astonishing 170,000 milliliters of filtered plasma every single day, just to produce an average daily output of about 1,200 milliliters. And when you break down that 1,200 milliliters, normal urine is overwhelmingly water, about 95%. Only 5% of it consists of actual dissolved solutes.
So let's look closer at that 5%. Those solutes are divided into organic and inorganic substances. The major organic solute is urea, which is a breakdown product of protein and amino acids from the liver. Urea is incredibly prevalent. It makes up about half of all the dissolved solids in your urine. You also have creatinine and uric acid. On the inorganic side, chloride is the primary constituent, followed by sodium and potassium. So here's a very practical takeaway. If you're ever handed a mysterious fluid and you need to confirm if it's actually urine, you just test it for high levels of urea and creatinine. If they are significantly higher than plasma levels, boom, you've got urine for sure.
Moving right along to Section 2, Urine Volume Variations, Decoding the Output.
Now, the amount of urine a body produces is largely dictated by hydration. The normal range is anywhere from 600 to 2,000 milliliters per day, with the average sitting right around 1,200 to 1,500. You really need to memorize these clinical thresholds. Oliguria is a significant decrease in output defined as less than 400 milliliters per day in adults, and that's often caused by severe dehydration from vomiting, diarrhea, or burns. Anuria represents a complete, dangerous cessation of urine flow, pointing to severe kidney damage or blocked renal blood flow. On the flip side is polyuria, an abnormally high output exceeding 2,500 milliliters a day, which can be caused by certain diseases or even just diuretics like coffee and alcohol.
Now, watch out for this classic exam trap comparing two completely different diseases that both cause polyuria. In diabetes mellitus, a lack of insulin leads to excess glucose spilling into the urine. Because glucose is a large, heavy molecule, it pulls water with it. But here's the trick. While the urine looks pale and dilute, it actually has a very high specific gravity because of all that dissolved glucose. Contrast that with diabetes insipidus, which is a decrease in antidiuretic hormone, or ADH. In diabetes insipidus, the kidneys just can't retain water, so you get massive polyuria, but with a genuinely low specific gravity and totally normal glucose and ketones. Keep in mind, patients with either condition will complain of polydipsia, meaning excessive thirst.
Section 3, Collection Methods Explained, Getting the Sample Right. How we get the urine completely dictates what tests we can run. The random collection is the most common and is great for routine screening, but it might be too dilute. First morning voids are much better because they're the most concentrated. Then we have the midstream clean catch, or a CCMS. This is where the patient cleanses the area, voids the first half into the toilet, and catches the second half in a sterile container, perfect for bacterial cultures. For quantitative chemistry, we use a 24-hour timed collection. The patient discards their very first morning void on day 1 and then saves all subsequent voids for exactly 24 hours. A great pro tip here is checking the creatinine level of the 24-hour sample. If it's greater than 1.0 milligrams per milliliter, it confirms the patient gave you a complete collection.
There is a stark contrast between some of our specialized collection methods. On one hand, you have the pediatric U-bag, which is a soft, adhesive bag placed over an infant's genitalia. It's often necessary, but it carries a super high risk of contamination. On the other extreme, you have suprapubic aspiration. This involves inserting a needle directly through the abdomen into the bladder. Because it completely bypasses the urethra, it is considered the absolute sterile gold standard for bacterial cultures.
Moving to Section 4, Containers, Transport, and Rejection, the gatekeepers of quality. A proper specimen container has to be clean, dry, leak-proof, wide-mouthed, and flat-bottomed. They should hold at least 50 milliliters, though the bare minimum you need for an automated analysis is 12 milliliters. And here is a cardinal rule of the lab. The patient label must go on the cup itself, never the lid. Lids get unscrewed, they get swapped, they get thrown away. And an unlabeled specimen is a useless specimen.
All urine specimens have to be transported to the laboratory in sealed biohazard bags. This prevents dangerous leaks and ensures chain of custody protocols, which is especially critical if you're dealing with drug testing. Transporting the requisition form and the matching specimens securely together is absolutely vital. If you only take away one thing as a clinician sending samples to the lab, please let it be this list of strict rejection criteria. Labs must have written policies for this. We will reject containers that are unlabeled or where the label doesn't match the requisition. We absolutely reject samples contaminated with feces or toilet paper. If there's an insufficient quantity, often called QNS for quantity not sufficient, we reject it. We also reject samples missing the correct preservative, or if a culture was submitted in a non-sterile container. It's harsh, but it ensures quality.
Section 5. Handling and Specimen Preservation, Racing Against the Clock. Once that sample is in the cup, time is literally of the essence. Urine needs to be tested within 1 to 2 hours of collection. Changes don't just happen inside the body, they happen in vitro, sitting right there on the counter, mostly due to bacteria. If a delay is inevitable, routine refrigeration at 2 to 8 degrees Celsius is the absolute best preservative to halt bacterial growth for up to 24 hours. But here's the catch. Refrigerating urine often makes amorphous urides and phosphates precipitate out, making the sample cloudy. So you must remember to warm the specimen back up to room temperature for about 15 minutes before running chemical tests. If the urine is too cold, the enzymatic reactions on your reagent strips slow down, and you're going to get false negative results.
Unpreserved urine sitting out for more than 2 hours is basically a free-for-all. As bacteria multiply, they produce an enzyme called urease, which breaks down urea into ammonia. This dramatically shoots up the pH, making the urine alkaline and creating that strong ammonia smell. Bacteria also convert dietary nitrates into nitrite, causing nitrites to increase. Turbidity goes up too. Meanwhile, other things are dropping. Glucose is literally eaten by the bacteria. Ketones just volatilize right into the air. Bilirubin gets photooxidized by the room light. And delicate things like red blood cells, white blood cells, casts, and the parasite Trichomonas all lyse and disintegrate in that dilute alkaline environment. Because knowing exactly what goes up and what goes down is so critical, these two mnemonics are lifesavers. For the things that increase in unpreserved urine, think NBA plays tonight. Nitrite, bacteria, alkaline pH, and turbidity. For the things that decrease, remember, go keep both urines cool. Glucose, ketones, bilirubin, urobilinogen, and cells or casts. Write those down.
Now, when refrigeration just isn't an option, labs rely on chemical preservatives. Boric acid is fantastic for transporting culture samples because it's bacteriostatic and keeps the pH around 6, though it can mess with certain hormone assays. Formalin is an awesome preservative for cellular sediment, but beware, it's a strong reducing agent and will completely ruin your glucose, blood, and leukocyte estrase strip tests. Finally, sodium fluoride is a solid choice for drug analyses, but again, it will inhibit several reagent strip tests. It's all about trade-offs.
And finally, Section 6, Exam Must-Knows, and next, the High-Yield Summary.
Let's rapid-fire the must-knows. Urea is your primary organic solute, half the dissolved solids. Chloride is the #1 inorganic. The suprapubic aspiration, that's your sterile gold standard for cultures. First morning voids give you the most concentrated sample. To make sure a 24-hour collection is complete, check that the creatinine is over 1.0 milligrams per milliliter. Remember to always refrigerate, then warm back to room temp. And finally, the ultimate exam trap. If a freshly voided sample reads a pH of 9 or higher, That is physiologically impossible. Human kidneys just don't do that. It immediately tells you the specimen is old, bacteria have taken over, and it absolutely has to be recollected.
So, we've successfully formed, collected, properly labeled, and preserved our urine sample. It is sitting securely on the lab bench, ready to go. But before we drop any chemical strips into it or slide it under a microscope, what is the very first thing the lab tech is going to evaluate? Think about that physical appearance as we wrap up today, because in part 3 of our Explainer series, we're finally cracking open these containers to examine the macroscopic properties, color, clarity, and specific gravity. See you then!